Hello, everyone. Good morning. I'd like to start by thanking the committee for selecting this talk for this session. And I have no conflicts of interest to disclose now. Okay. So I'd like to acknowledge that the land that I work, live, and play, and where this work was carried out, is the unceded territory of the Coast Salish peoples. That includes the territories of the Tsleil-Waututh, Musqueam, and Squamish nations, and that is Vancouver, British Columbia, Canada. I'd also like to start off by talking a little bit about language. In this presentation, we are going to use the term women. Now, this is going to describe people that are assigned female sex at birth, are cisgendered women, for the purpose of the analysis I am presenting today, even though the study was inclusive of more individuals that identified as women. We acknowledge that not all people that are born with a uterus identify as women, and not all those identifying as a woman are born with a uterus. So for what I'm presenting today, that is how we are taking this, but it is not an inclusive definition of all the different experiences out there. So ovarian function is critical to a woman's health, and ovarian sex hormones, our estrogen and our progesterones, fluctuate throughout life, and they're protective to many different body systems, including but not limited to bone, heart, and liver. Liver being obviously what I'll discuss today. Now, this is a schematic with no real values, just kind of giving you a sense of fluctuation of these ovarian sex hormones throughout life. So we see they start to rise sort of at different levels throughout puberty. They are highest during menstruating years, or some papers will call this reproductive life. Now, this figure does not show the cycling of the menstrual cycle. It is just showing it is highest during this period. Begins to decline in that perimenopause phase, being its lowest when you hit menopause, and then in the post-menopause duration, until death when it, drops. So, in my title, I had abnormal ovarian function. We're going to start by talking about amenorrhea. Now, amenorrhea is more than 1 year without menstruation during those normal menstruating years. Women living with HIV in British Columbia were more likely to experience prolonged amenorrhea unrelated to things such as pregnancy, lactation, contraception, surgery, or menopause. Prolonged amenorrhea has generally been associated with lower ovarian hormone levels in other cohorts. We also know that low ovarian hormone levels have been associated with accelerated liver fibrosis or liver disease. So the question was, what is abnormal ovarian function doing, and may it place women at higher risk for liver disease if they are experiencing this? So our study aimed to examine the potential associations between history of abnormal ovarian function and liver disease in women living with and without HIV. So to take those words and put it into a graphic for you, we know from the literature that low ovarian hormones have been associated with both experiencing amenorrhea, or that lack of normal menstruation for at least a year, as well as poor liver health outcomes. The question we are looking at is, do we see an association of having amenorrhea, or this abnormal ovarian function, with liver health outcomes being our fibrosis index? You're just going to stare at what I'm going to be talking to you about today for a little longer. There you go. So the two cohorts that this study took place in, you have already been introduced to. That is the British Columbia Karma-Chivos Collaboration, or BCC3 study, and the Karma cohort by my two colleagues, Tatiana and Lulu, that were earlier this morning. So BCC3 is data from 2020, and it is ongoing, so till present, and it enrolls individuals self-identifying as a woman and are cis and trans inclusive studies. Karma, for the purposes of the data that we extracted, was from 2008 to 2018 and enrolled people of any sex or gender. For what I'll be presenting to you today, we took the most recent visit of a participant, so they may have been in both studies. We took the most recent one as of November 2024. We then looked at individuals that were sex-assigned female at birth and responded to the reproductive health questionnaire, and that's so we could get the information on the abnormal ovarian function. So that gave us 767 participants, and then we removed participants that were missing data for HCV serostatus and the variables needed to calculate the liver fibrosis, or Fib4 index. So that leaves us with a total N of 564 for those of you at the back that can't read the bottom of my slides here. So liver disease fibrosis, or FIB4, is a calculation that you can do from normal liver enzymes. We use 2 of them, aspartate aminotransferase, or AST, and alanine aminotransferase, or ALT. So it looks at age by your AST over your platelet count and the square root of the ALT. So you need all these different clinical parameters to calculate it, and then we categorize them based on low, intermediate, and high for clinical significance on where you might be falling within this fibrosis FIB4 index. History of abnormal ovarian function for the purposes of our study was defined as a history of prolonged amenorrhea, so that more than 12 months or more of no menstruation, premature ovarian insufficiency, and this was biochemically confirmed using follicle stimulating hormone, or FSH, with ages less than 40 years, and then early menopause, which would be less than 45 years. Polycystic ovarian syndrome, individuals experiencing this were excluded from the analysis as they don't actually have that low ovarian sex hormone levels. And then our analysis was segregated based on HCV seropositivity. And this is because opioid use is known to induce amenorrhea by shutting down that hormonal access. And in our cohort, opioid use and HCV were collinear. So you can't put them both within the model to understand what's going on. So we segregated it by HCV serostatus to be able to look at the effect of opioid use and abnormal ovarian function at the same time. So for our demographics, at the top here, you see our fibrosis FIB4 index. Now, it's a busy table. So the first group that you see here is our HCV seropositive participants, and then divided into women living without HIV and women living with HIV, and looking at the differences within that group. And then the second, on sort of the far side over by where everyone is sitting on the other end there, is our HCV seronegative participants, and then divided up the same, women living without HIV and women living with HIV. Now, like Tatiana and Lulu said, these cohorts were recruited to have sociodemographically similar controls, or women not living with HIV. So we really only see our fibrosis, or FIB4 index, being different between our groups. Our age was in our 50s to 40s, depending on the group. So this enrolled individuals from 16 all the way up to, I think our oldest in this analysis is around 80. So it's a pretty wide age range of individuals. Ethnicity was entered into our model as white versus racialized, to use that as a surrogate marker of racism within the health system, and when someone may be presenting to get treatment or to understand, but the demographics are very similar to what was presented earlier. And then we used alcohol use, opioid use ever. Now, opioid use ever includes both illicit opioid use and prescription opioid use, smoking ever, and body mass index. So looking at the univariate analysis with the continuous fibrosis-4 on our y-axis for our 2 outcome measures of interest. So living with HIV first, we see on the left-hand side of your graph here, the HCV seropositive participants, with women living with HIV in pink and women not living with HIV in gray. And then the other side of the graph is our HCV seronegative participants, and we do see a higher fibrosis FIB4 index, especially in our HCV seropositive group, but a trend in our HCV seronegative group as well. When looking at our abnormal ovarian function, the coloring is the same. So the pink dots are showing you the women living with HIV, and the gray dots are showing you the women not living with HIV, but now it is divided into yes or no experiences of that abnormal ovarian function. We do not see a difference with our fibrosis, or FIB4 index, between these 2 groups univariately. Oh, I barely touched it that time. When you look at our multivariate model, again, it is the same here. We have our HCV seropositive participants on the side kind of closest to where I'm standing, and HCV seronegative participants on the far side. You see all of the different variables that we entered into our multivariate model, with our 2 outcomes of interest at the top there, living with HIV being in my orange box. And in both cases, we do see that living with HIV was associated with a higher fibrosis, or FIB4 index. Now, I would like to note we have done some reanalysis since the abstract was submitted, so the estimate numbers you see here are slightly different than the abstract, but the story has not changed. Okay, so if you're looking at the abstract and going, it was 0.31, now it's 0.41, that's what's going on there, okay? Our abnormal ovarian function was not associated with an increase in fibrosis-4 index in either of our 2 groups. And then you do see the other variables, sociodemographic variables we controlled for. I will note that increasing age was associated with increased fibrosis-4, and we do see in our HCV seropositive participants a slight decrease with body mass index, but that is our smallest sample size group, so we do, take a little bit of caution when you're interpreting that data there. So to summarize it all up, what were we looking at? So our study aim was to examine the potential association between history of abnormal ovarian function and liver disease among women living with and without HIV within the context of British Columbia, Canada. In our adjusted analysis, we see that history of abnormal ovarian function showed no independent association with liver fibrosis, but living with HIV amplified liver fibrosis independent of older age, alcohol and opioid use, and those other sociodemographic factors we put in our cohort. So again, that is only really, you can take that with a sort of a grain of salt if you're looking in a different context for different experiences of amenorrhea. And I would like to acknowledge the BCC3 and CARMA participants, as well as the BCC3 team members that have been instrumental in my time with them, in particular the community research associates who are women living with HIV trained in research that are with us every step of the way. The community partners, the 3 that I have had the privilege of working with, and the many more that the wider team has worked with, our affiliations and funding, and then in particular the International Workshop on Women in HIV Scholarship Committee that has allowed me to actually be here to present in person to you today. And references if anyone is interested.